Thanks, Steve. Thank you for this opportunity to tell you about what's going on in Kansas. I'm Rick Kellerman. I chair the Department of Family and Community Medicine at the University of Kansas School of Medicine in Wichita. And to explain this, you have to understand a little bit about the geography of our state. We're a pretty big state. We're located right in the middle of the United States. There are two major metropolitan areas, Kansas City, which is on the border of Kansas and Missouri. The other major metropolitan area is Wichita. And we have had a chronic shortage of physicians, particularly in our rural areas. The state has a population of about 3.5 million people. Half of those live in the Kansas City metropolitan area or in Wichita. The other half live in the rest of this large geographic area. In fact, about a third of the state isn't rural. It classifies as frontier, which is less than 6 people per square mile. So we're a very rural state. Well, Kansas City is where the University of Kansas Medical Center is located, and it's actually located right on the state line between Kansas and Missouri. So as you can imagine, this is a large medical center complex. It's very vertical. It's large buildings that go vertically up in a city block. And there's a large gravitational pull to train medical students and residents, and a large gravitational pull for physicians to stay in that Kansas City market. In 1971, along with a lot of other states, a regional campus was developed in Wichita. And that campus historically has taken 50 to 60 third-year students and 50 to 60 fourth-year students. And the class starts, everybody starts in Kansas City. They do their first 2 years of basic sciences there. And then 50 to 60 people come to Wichita. We've been very successful, particularly in primary care. About 1 out of 3 of our students on the Wichita campus end up in family medicine. And of the residency graduates, about a third stay in Wichita. We have about 250 residency graduates each year. About a third stay in Wichita. About a third go to rural areas of our state. And again, these are very rural areas. And about a third go to contiguous states. And most of those that go to Oklahoma, Nebraska, Colorado also go to rural areas. 3 years ago, we started a process of adding the first 2 years of medical school in Wichita, and that's the expansion that I want to talk about. And the question is, can you expand the first 2 years without redeveloping an entire basic science department? Now, Wichita has been community-based. We only have about 100 paid faculty. We use about 1,000 volunteer faculty who are private physicians. We use community hospitals, nursing homes, and private physicians in Wichita and throughout the state of Kansas. And so we decided to start this first 2 years in Wichita. First of all, we have one basic scientist in Wichita who organizes everything, and most of the lectures originate in Kansas City and are televised to Wichita. There are some in Wichita that are televised to Kansas City. But what's the first thing you notice? There are 28 medical students now in the first year. Here's their lecture. What do you notice about this lecture hall? There are no students in there. Students don't go to lectures. So all of the lectures are podcast, and the students oftentimes sit at home and watch the podcast, and just like this webinar. And what the students tell us is, have you ever been in a lecture that it's very technical and you get lost 5 minutes into the lecture, and then for 55 minutes you don't know what's going on? Well, the students can rewind this and, catch up with what they missed. They also tell us that some of the lectures speak very slowly, and they can put the podcast on double time and get through an hour lecture in 30 minutes. So I've become a believer in podcasts. What's probably more important, though, is the students work in small groups of 7. And here we have a bioscientist who helps facilitate those small groups. We use the bioscientists at Newman University, which is a private school in Wichita, and then Wichita State, which is another Regents University. And it's really the facilitators that bring meaning to the basic sciences of the lectures. We also use problem-based learning. This is Dr. Scott Moser, who's running one of the problem-based learning sessions, where we give the problem to the medical students, and they have to figure out what's going on. And so through these mechanisms, we've been able to drive down some of the clinical care that historically only occurred in the 3rd and 4th year into the first 2 years. One of the problems with this transition between the 1st and 2nd year and the 3rd and 4th year and the move to Wichita after the 2nd year was that families had to be disrupted. They did their first 2 years in Kansas City, then they had to move to Wichita, and also the curriculum had to be disrupted because there had to be a hard stop at the end of the 2nd year and then move into the 3rd and 4th years for clinical work. So by having all 4 years in Wichita and in Kansas City, we've been able to move some of the basic sciences back into the 3rd and 4th year and move more clinical care into the first 2 years. This is Newman University. As I mentioned, we work with the bioscientists there and at Wichita State University. We try to move the clinical care into the first 2 years. In fact, our goal is to really, on the very first day of medical school, all of the students will see a patient. And we use clinical faculty who are in private practice in Wichita. All of the medical students in their 1st and 2nd year are assigned a clinical preceptor that they spend time with in the office or in long-term care settings and sometimes in the hospital. We also are integrating the first 2 year students into the JDOC clinic, which is a student-run clinic that we've had for 10 years, which primarily had involved 3rd and 4th year students previously. We use a lot of simulation and standardized patients. You know, when we started the standardized patient program about 15 years ago, one of the faculty came to me and said, you know, we need standardized patients. I said, well what for? We've got patients, we've got them in hospitals, we've got them in doctors' offices. What do we need these fake patients for? And the faculty member said, Rick, how do medical students learn to give bad news? Well, they really don't have the opportunity with patients. And so, just as an example, we use the standardized patients and we have a bad news patient where the medical student has to sit down and learn to give bad news. We put a lot of emphasis on communication skills and interpersonal skills. This is Dr. John Dorsch, who's working with one of the medical students reviewing with a standardized patient. This is one of our clinical preceptors, Dr. Diane Nightingale, who's in El Dorado, Kansas, a rural community, who was the outstanding volunteer teacher from the American Academy of Family Physicians nationally about 15 years ago. We do some training in the hospital, but really those first 2 years are outpatient and in the community. Finally, is this scalable? At the same time we moved the first 2 years to Wichita, we started another campus of 8 students who do their entire 4 years in Salina, Kansas, a town of about 45,000 in north central Kansas. In conclusion, we just went through an LCME review and got flying colors for all 3 campuses. So we're really proud of what's going on in Kansas. The ultimate outcome is to provide physicians for those 400 people, mile-wide state, and 200 miles wide in our state. So thank you, Steve.
Thank you, Rick. Our next speaker is Mary Patterson with the American Association of Colleges of Nursing.